We're talking about the diseases of white blood cells, lymph nodes, spleen, and the thymus.
And this isn't just a broad overview. Our mission for you, the learner, is to provide really the ultimate shortcut to being well-informed on this incredibly dense subject matter.
Exactly.
We are systematically walking through the entire spectrum, from the normal function of blood production to the body's appropriate reactive changes, and then finally into the aggressive and often insidious hematologic cancers.
And we're not just reading definitions here. We are aiming for granular, applied knowledge. I mean, we are drilling down into the microscopic morphology, what these disorders actually look like under the microscope.
Yes.
What specific genetic drivers push them into existence, and, why recognizing these details matters for a patient's prognosis. So get ready for a serious infusion of visual pathology insights.
And to achieve that, we will integrate the information from the core diagrams and tables naturally into our conversation.
They're essential.
They really are. I mean, these visuals are the indispensable roadmaps to differentiation, classification, and immunophenotyping. By focusing on that structure and these high-yield concepts, we can tackle this detail without feeling, completely overwhelmed by information overload.
Let's do it. Let's start with the foundation, the hematopoietic system.
Okay.
Traditionally, we organize this vast system into two components. You've got myeloid tissue, which is primarily the bone marrow.
Right, the factory.
And then lymphoid tissue, which includes the spleen, lymph nodes, and the thymus.
That organizational distinction is, look, it's incredibly useful for teaching, but it is fundamentally artificial.
Artificial how?
Well, both of these tissues are composed of cells that derive from common hematopoietic precursors. They both ultimately affect the composition of the circulating blood, and in disease states, the two systems frequently interact. They're not isolated.
So a problem in one is almost always going to cause a problem in the other.
Almost inevitably. For example, a severe lymphoma, which is a lymphoid proliferation, will inevitably cause secondary changes or even failure in the myeloid-producing bone marrow.
And that's really why we're covering this entire spectrum, from white cell cancers to red cell defects that lead to anemia or platelet and hemostasis issues.
Right.
It's because every one of these problems stems from disturbances in the development of those initial white cell precursors.
That's it. If the bone marrow factory is defective at the source, everything downstream is going to be affected.
Okay, so let's talk about that factory. This is where it gets really interesting. Watching cells commit to their destiny.
It's a beautiful process.
If we look at that core diagram of blood cell differentiation, figure 13.1, it feels like the single most important schematic for understanding this entire field. Can you walk us through the hierarchy of commitment?
Absolutely. We have to begin at the very top, at the apex, with the hematopoietic stem cells, the HSCs.
Master cells.
They are the master cells. They're pluripotent, which is a fancy way of saying they can become any mature blood cell. But critically, they possess the essential capability for self-renewal.
And that's the magic trick, isn't it? The self-renewal.
It is the absolute magic trick. This ability to clone themselves indefinitely is why HSCs are the linchpin for procedures like bone marrow transplantation. You're giving someone a new, self-renewing factory.
So the HSCs are the self-replenishing CEOs of the factory, but then they hand off production to managers who start specializing.
Precisely. They give rise to committed precursors or progenitor cells. The earliest major split is the multipotent progenitor, which separates into an early progenitor with defined lymphoid potential.
So that's your B cells, T cells, and NK cells.
Exactly. And on the other side, an early progenitor with dedicated myeloid potential.
And once we hit that myeloid side, the cell's fate is pretty much locked in.
Yes, lineage commitment is fixed. The myeloid progenitors separate into cells destined to become granulocytes, CFUG, monocytes, CFUM, megakaryocytes, the CFUMG, which produce platelet and erythrocytes, the CFUE for red cells. The key distinction here is that these committed progenitors have reduced or zero self-renewal capability.
So they're on a one-way trip.
They are on a one-way trip. They are destined to differentiate and eventually die. They are not immortal like the stem cells.
That intricate process must be so tightly regulated. Otherwise, you'd end up with a huge glut of one cell type and a deficit of another. How is that complex, constantly adjusting regulation achieved?
That is where the lineage-specific growth factors come in. These factors, which are often cytokines and chemokines, they act as the precise volume controls for the factory.
Like turning dials up and down.
Exactly like that. They bind to specific receptors on the progenitor cells. The sources highlight critical signaling components like the erythropoietin receptor or signals dependent on molecules like AKIT, and the FLK to FLT3 ligand.
So, for example, if your oxygen levels drop.
The system knows. Erythropoietin EPO signaling increases, boosting the output of the CFUE cells to make more red blood cells and carry more oxygen. The system ensures that production maintains the appropriate ranges. That's homeostasis in action.
Okay, so now we move from normal function to when things go wrong in a non-cancerous or reactive way. Let's start with leukopenia, the reduction in circulating white cells.
Right. And clinically, the most important form of leukopenia is neutropenia, a dramatic reduction in the neutrophil count.
And this is serious.
This is very serious because neutrophils are your absolute first line of defense against common invaders like bacteria and fungi.
So the consequence of losing that first line of defense is immediate and severe.
It's an increased susceptibility to severe, often life-threatening bacterial and fungal infections.
And what causes this? Where's the failure point?
Well, when we look at the causes, they generally break down into two categories. Either you're not making enough, so inadequate production, or you're destroying them too fast, accelerated destruction.
So let's talk about inadequate production first. That sounds like a fundamental marrow problem.
It is. It often stems from general marrow suppression. Think of aplastic anemia, or most commonly, drug toxicity.
So we're talking about chemotherapy or other medications like alkylating agents that just wipe out rapidly dividing cells, right?
Right.
Causing a massive general suppression of hematopoiesis.
Correct. The source specifically calls out drug toxicity as the most common cause of a granulocytosis. On the destruction side, you might see immune-mediated destruction, where the body is inappropriately targeting its own neutrophils, maybe associated with systemic conditions like lupus or rapid peripheral utilization.
Meaning you're just burning through them.
Exactly. A massive infection is burning through them faster than the factory can produce new ones.
Okay, now let's flip the script to leukocytosis, an increase in circulating white cells. This is usually the body's appropriate, measured response to infection or inflammation.
Usually, yes. But we have to understand that not all leukocytosis means the factory is running faster.
What do you mean?
Well, while increased marrow production due to chronic inflammation or a growth factor stimulus is a common mechanism, we also see these non-production mechanisms. Think about something called impaired extravasation.
That's a textbook term. Give us the conversational insight here. What does that mean in simple terms?
Okay, think of the white blood cells flowing through the blood vessels like passengers on a train.
Okay.
To fight an infection, they need to get off the train and enter the city, the tissue. Extravasation is that process of them leaving the vessel.
Right, exiting the train station.
Exactly. Certain hormones, particularly glucocorticoid steroids, are like security guards that prevent the cells from exiting the station.
Ah, so they're stuck on the train.
They're stuck on the train, they stay in the blood, artificially inflating the circulating count, even though the total output from the marrow hasn't necessarily increased. It's a crucial distinction.
That's an excellent clarification. Okay, let's get to the visual cues, the microscopic insights that allow pathologists to distinguish these reactive, benign changes from potentially frightening neoplastic ones. We need to talk about the morphology of reactive neutrophils.
This is absolutely high-yield information. If you're looking at a slide from a patient with a severe acute bacterial infection, you'll see neutrophilic leukocytosis, but the cells themselves look stressed.
Stressed how?
Yeah.
What are the visual changes?
We're looking for toxic granulations. These are coarse, dark cytoplasmic granules. We're looking for cytoplasmic vacuoles, and most importantly, dual bodies.
What exactly are dual bodies and what do they represent?
They are these pale blue cytoplasmic inclusions, usually seen near the periphery of the cell, and they represent remnants of dilated endoplasmic reticulum. It's a sign of cellular stress.
And if you're looking at that H&E image in the source material, figure 13.2, it becomes really clear.
It does. The arrow points clearly to these pale blue bodies sitting right alongside the dark purple toxic granulations. Recognizing these benign changes allows the pathologist to correctly diagnose a leukemoid reaction.
A leukemoid reaction, meaning it looks like leukemia.
It mimics leukemia with a very high white count, but it's the body's massive appropriate response. It is not cancer. Morphology tells the story of acute stress versus chronic malignancy.
And we see other patterns too, right? Eosinophilia.
Eosinophilia in allergic disorders and parasitic infections, and even in certain lymphoid cancers like Hodgkin lymphoma. Desiphilia and monocytosis often flag chronic conditions, such as chronic myeloid leukemia or chronic bacterial infections like tuberculosis.
Okay. We've established the normal factory output and its emergency response in the marrow, but the cells have to go somewhere. If we shift our focus to the secondary lymphoid organs, what happens when the lymph nodes react appropriately to an invader?
That is lymphadenitis. It's simply the inflammation and enlargement of lymph nodes, which is an expected part of the immune response. To interpret what we see, we must recall the basic node architecture.
The cortex, paracortex, and medulla.
Right. And you have the B cells and the follicles in the cortex, the T cells in the paracortex, and the plasma cells in the medulla.
And the morphology changes based on whether the B cells or T cells are taking the lead in the fight. Let's start with follicular hyperplasia.
Follicular hyperplasia is driven by a strong humoral or B-cell immune response. This often involves the creation of large, highly active secondary follicles.
And what does that look like on a low-power H&E view, like in figure 13.3a?
You see these massive germinal centers, these big pale circles, surrounded by a dark staining mantle zone of small resting B cells. Crucially, the normal structure is maintained, just dramatically amplified. The follicles are huge, but they're still distinct.
Okay, so zooming in on those active germinal centers really brings the pathology to life. If we're looking at the high-power view, what are we looking for to confirm this is a robust but benign reaction?
We look for the proliferating cells, the centrocytes and the centroblasts. But the absolute key is the presence of abundant tingible body macrophages.
Tingible body macrophages, what are they doing?
They are macrophages that have literally ingested the apoptotic debris, the remnants of B cells that failed their quality control checks during affinity maturation. They're cleaning up.
Ah, so this is where that classic starry sky appearance comes in.
Exactly. The scattering of clear, pale macrophages, the stars, among the darker proliferating B cells, the sky is the hallmark.
So the starry sky appearance here is actually a sign of intense, successful, and healthy antigen-driven B cell activity. The immune system is tidying up the debris from its own training camp.
That's a perfect analogy. It indicates a high-affinity immune response in progress.
And there are other patterns of reaction, too.
Yes, other patterns include paracortical hyperplasia, which is triggered by T-cell responses to acute viral infections like infectious mononucleosis, or sinus histiocytosis, where the lymph node sinuses are enlarged due to an increase in benign macrophages.
And that one is often associated with something more sinister nearby.
It is. It's a pattern often associated with nodes that are draining an underlying cancer, like breast carcinoma.
Okay. This next topic moves us from an appropriate reaction to a catastrophic runaway reaction. Hemophagocytic lymphohistiocytosis, or HLH.
HLH.
This sounds like a rare but extremely serious condition marked by systemic inflammation.
It is. HLH is sometimes referred to as macrophage activation syndrome, and it's a true immune emergency. To use an analogy, imagine your immune system's thermostat breaking and causing a runaway fever.
A cytokine storm.
A massive cytokine storm. It's driven by the hyperactivation of macrophages and cytotoxic T cells, your CD8 plus cells.
When what triggers this failure of immune regulation?
It can be familial, involving inherited defects in the ability of those cytotoxic cells to properly kill their targets. Or, more commonly, it's secondary.
Triggered by something else.
Right. Triggered by severe infections, especially Epstein-Barr virus, EBV, systemic rheumatologic disorders, or underlying hematologic neoplasms. When the cytotoxic T cells fail to deliver their target killing punch, they instead just pump out massive amounts of inflammatory mediators like IFN gamma.
And clinically, this must be a devastating presentation.
It is. Patients present acutely ill with intractable fever, significant splenomegaly, and hepatomegaly.
And the lab work?
Lab work shows severe pancytopenia low counts of all cell lines, dramatically elevated ferritin, and often evidence of disseminated intravascular coagulation, or DIC.
How is the diagnosis confirmed?
It's confirmed by finding evidence of hemophagocytosis macrophages literally eating other blood cells in the bone marrow or spleen. It's an urgent, life-threatening condition that requires intense immunosuppressive therapy.
Okay. Now we cross the critical line from reactive states into cancer. The clonal, malignant proliferations of white cells.
The lymphoid neoplasms.
Yes. And these are proliferations of B cells, T cells, or NK cells. A key conceptual point is the division between leukemia and lymphoma.
It's an important, if sometimes blurry, line. Leukemia originates primarily in the bone marrow or is found circulating in the blood. Lymphoma is primarily a mass in lymph nodes or soft tissue.
But the distinction can be blurred.
Very often. For instance, acute lymphoblastic leukemia is often also considered a lymphoma when it forms a mass. They're two sides of the same coin.
To organize this complexity, the WHO classification categorizes these tumors by their lineage. But since these tumors can look similar, how does the pathologist truly identify the cell type? What's the tool?
The tool is immunophenotype. We use specific CD markers, which are surface proteins that act as fingerprints for the cell of origin and its stage of maturity.
So you're staining the cells to see what flags are flying.
Exactly. For example, precursor B cells, the lymphoblasts, might express CD10 and CD19. Mature B cells express CD20. These markers, detected via flow cytometry or specialized stains, are the defining diagnostic feature that assigns the tumor to its WHO category.
Let's start with acute lymphoblastic leukemia lymphoma, or AL. This is the poster child for pediatric cancer, the most common cancer in children, peaking around age 3.
It is. All L is a tumor composed of immature B or T cells, the lymphoblasts. The vast majority, about 85%, are BALs.
And the TALs?
TALs are less common and often present in adolescent males as a localized mass in the chest, arising from the thymus.
What's happening at the genetic level? What drives the pathogenesis of AL?
It's driven by genetic mutations in transcription factors, specifically those needed for normal B or T cell development.
So the master switches are broken.
The master switches are broken. Mutations in things like NOTCH1 and TAL or PX5 and RUNX1 and BAL create a scenario where the cell's maturation is completely blocked, while its self-renewal capacity is turned way up.
So the cell is perpetually stuck in an immature dividing state.
That's it, exactly.
Let's look at the morphology of these dangerous immature cells. What do we see in the marrow, for instance, in figure 13.6?
In the bone marrow, the normal tissue is aggressively replaced by these lymphoblasts. Microscopically, these blasts are small to medium size. They're generally monotonous.
You mean they all look the same?
They all look the same. They have delicate nuclear chromatin, small nucleoli, and only scant cytoplasm. The marrow is often just packed shoulder to shoulder with them.
And the definitive sign of their immaturity, the one killer test.
That would be the nuclear enzyme terminal deoxynucleotide transferase, TDT.
TDT.
TDT is the key marker for both precursor B and T cells. If you see TDT positivity, you know the cell is stuck in the earliest stages of development. We use flow cytometry plots, identifying markers like CD19 and CD10 for BAL or CD3 and CD5 for TAL alongside TDT to confirm the diagnosis.
Clinically, the onset is abrupt, with symptoms stemming from bone marrow failure, fatigue, easy bruising, recurrent infections.
And sometimes mass effects from the tumor growth itself.
What determines prognosis? Because this is one of the big success stories in oncology.
It is, especially in children. Children generally have an excellent prognosis, with 95% achieving complete remission, but the prognosis severely declines with age.
So an adult getting AL is a much more serious situation.
Much more serious. Prognosis also worsens if the patient presents with a very high initial white blood cell count, and especially if specific adverse genetic translocations are present.
Such as?
For example, the presence of the BCR-ABL fusion gene, the Philadelphia chromosome, which is usually associated with CML when it shows up in AL, it signals a far, far worse outcome.
Okay, moving to the adult world, we have chronic lymphocytic leukemia, small lymphocytic lymphoma, or CLL/SLL. This is the most common adult leukemia in the Western world, usually diagnosed around age 70.
And right off the bat, it's important to state they are biologically the exact same disease.
It just depends on where you find it.
Precisely. CLL means the proliferation is dominant in the circulation, so you have a high lymphocyte count in the blood. SLL means it presents as a tissue mass, typically lymph node enlargement.
The morphology is fascinating here, especially on the peripheral smear. What's a classic finding?
If you look at the peripheral blood smear, like in figure 13.7b, the defining feature is the presence of smudge cells.
Smudge cells?
These are the fragile, malignant lymphocytes that literally rupture when the smear is being prepared. They just look like purple smudges on the slide. The intact cells are small, round lymphocytes with very little cytoplasm and dense, clumped nuclear chromatin.
And in the lymph node, we see those specific growth centers.
Yes, in SOL, the normal lymph node architecture is wiped out by a diffuse infiltrate of these small cells. But interspersed within this mass are the proliferative centers.
What are those?
They're aggregates of slightly larger, more active cells that represent the growth faction of the tumor. Seeing those centers is highly characteristic of SLL.
The immunophenotype has a unique diagnostic fingerprint involving a marker you wouldn't expect in a B-cell tumor.
This is absolutely essential. CLL/SLL is a B-cell neoplasm, so it's CD19, CD20, and CD23 positive. But it co-expresses the T-cell antigen CD5.
which is very strange for a B cell.
It's highly unusual, and that co-expression is almost pathognomonic for CLSLSL. They also feature very low levels of surface immunoglobulin expression.
A key clinical complication here is linked to immune dysfunction, isn't it?
Yes. Due to the underlying immune dysregulation caused by the malignant clone, 10 to 15% of patients develop autoimmune hemolytic anemia.
So their own immune system starts attacking the red blood cells.
Correct. The course of the disease is highly variable, but prognosis is strongly linked to cytogenetics, particularly deletions on chromosome 17p and 11q, which are bad news.
Let's move to follicular lymphoma, or FL. This is the second most common non-Hodgkin lymphoma. You describe it as the definition of an indolent, slow-growing cancer, which is often incurable with standard therapy.
It's a paradox, isn't it? It's slow, but it's stubborn. Its pathogenesis is defined by a single critical genetic mistake, the T14/18 translocation.
Okay, what does that translocation do?
It moves the BCL2 gene from chromosome 18 right next to the very powerful IgH locus on chromosome 14. This drives massive overexpression of the BCL2 protein.
Let's focus on that insight.
Right.
Why is BCL2 overexpression the key? What does it do?
PTCL2 is an anti-apoptotic protein.
So anti-death.
It's the ultimate cellular survival cheat code. Normally, B cells that make mistakes during their development in the germinal center must undergo programmed cell death apoptosis. Overexpression of BCL2 provides immortality.
So these tumor cells don't necessarily grow faster.
No.
They simply refuse to die when they should.
That's the perfect summary. This prolonged survival explains why FL is typically slow-growing but persistent and very difficult to eradicate completely.
The morphology clearly reflects the name follicular.
It does. If you look at the nodal H&E slide in figure 13.10, you see a clear nodular or follicular growth pattern, but these follicles are abnormal. They're poorly defined, packed back to back, and they replace the normal lymph node structure completely.
And what's inside them?
The neoplastic follicles contain a mix of small cleaved cells, which we call centrocytes, and larger non-cleaved cells, the centroblasts.
And to definitively prove that this is a malignant follicle and not a reactive one, you use immunohistochemistry.
Yes, this is a brilliant diagnostic trick. Reactive, healthy follicles are BCL2 negative because B cells in there are supposed to be dying off constantly as part of quality control.
Right.
But in follicular lymphoma, as you can see in figure 13.12, the tissue shows strong, diffuse brown staining for BCL2 within the neoplastic follicles. That confirms their malignant nature. They also express classic germinal center markers like CD10 and CD20.
Okay, so if follicular lymphoma is slow and chronic, diffuse large B-cell lymphoma, or DLBCL, is the inverse.
It is the complete inverse. It's the most common form of NHL overall, it's highly aggressive, and it typically presents as a rapidly enlarging mass.
What's driving this aggression?
DLBCL is a heterogeneous disease. It's driven by multiple genetic pathways, frequently involving rearrangements of a gene called BCL6 or overexpression of BCL2, sometimes through that same T14/18 translocation. All these pathways converge on one goal: aggressive proliferation and survival signals.
And the name gives away the pathology: diffuse, large, B-cell.
Exactly. The H&E image in figure 13.13 shows a complete effacement of the normal architecture. It's replaced by a diffuse growth pattern of huge abnormal B cells.
How large are we talking?
These neoplastic cells are enormous, easily 5 times the size of a normal lymphocyte. They have large nuclei, open vesicular chromatin, and very prominent nucleoli.
Despite its rapid growth and aggression, DLBCL is often curable.
Absolutely. This is the aggressive tumor you want to have, if you have to have one. It is highly responsive to initial chemoimmunotherapy, especially with the use of anti-CD20 antibodies like rituximab. That can lead to a cure in 60 to 80% of patients.
And they can pop up anywhere, right? Not just in lymph nodes.
Correct. They often present in unusual extranodal sites like the GI tract, the skin, even the bone.
Let's move to Burkitt lymphoma. This is arguably the fastest growing human tumor.
It's incredibly aggressive. It's categorized by 3 distinct types: endemic, which is the African type that often involves the jaw; sporadic, which is non-endemic and often involves the abdomen; and HIV-associated.
And the genetic hallmark here is all about one gene.
It's all about MYC. The hallmark is the MYC gene translocation, most commonly T814. This action places the MYC oncogene next to the powerful IgH locus promoter, resulting in massive, continuous overexpression of the MYC protein.
And MYC is the accelerator pedal for cell division.
It is the ultimate cell cycle promoter. It leads to explosive cell growth and division. This rapid replication also forces the cell to change its metabolism, favoring the Warburg effect aerobic glycolysis to produce the huge amounts of building blocks necessary for such fast replication.
Okay, let's revisit the morphology here, because we saw this appearance earlier in a benign setting. The classic starry sky appearance.
This is a crucial point of distinction for the pathologist. In Burkitt lymphoma, if you look at figure 13.15, the dark staining, rapidly proliferating medium-sized tumor cells, the sky, are interspersed with scattered, pale, non-neoplastic macrophages, the stars.
Well, why are the macrophages there?
Because the tumor is growing so fast, it is also undergoing massive spontaneous apoptosis. The cells are dying just as fast as they're being born, and the macrophages are there to clean up the sheer volume of resulting debris.
Wait, you mentioned earlier that the starry sky and reactive lymphadenitis was a sign of healthy cleanup. Now we see it in Burkitt, the most aggressive cancer. How does a pathologist differentiate between something benign and this tumor if they look visually similar?
That is an excellent question that highlights the art of pathology.
It seems tricky.
It is. In reactive follicular hyperplasia, the overall lymph node architecture is maintained, and the stars are mostly concentrated in the germinal centers. In Burkitt lymphoma, the infiltrate is completely monomorphic, the tumor cells all look the same, and the normal node architecture is totally effaced by this sheet of cells. The pattern is diffuse, not follicular, and the proliferation rate is astronomically high, confirming malignancy.
Okay. And despite its aggression, that fast-growing nature makes Burkitt highly sensitive to intensive chemotherapy.
Very sensitive, often leading to rapid, good outcomes if caught and treated aggressively.
Next up, mantle cell lymphoma, or MCL.
Mantle cell is a small percentage of NHLs, but it's aggressive and defined by one key genetic event, the T1114 translocation.
Which puts the cyclin D1 gene next to the IGH locus.
Correct. This leads to the overexpression of cyclin D1. Cyclin D1 is a protein that is essential for pushing the cell past the critical checkpoint from the G1 phase, growth, to the S phase, DNA synthesis.
So it's another way of forcing the cell into proliferation constantly.
Exactly. It's a direct assault on the cell cycle's brakes.
Microscopically, the cells are small to intermediate, and the pattern can be diffuse or vaguely nodular.
The classic finding, though, is the mantle zone pattern. The neoplastic cells tend to surround and infiltrate the remnants of atrophic germinal centers, mimicking the mantle zone of a normal follicle, as you can see in figure 13.16.
Then clinically?
Clinically, it often presents at an advanced stage with generalized lymphadenopathy, and it often involves the GI tract. Its median survival has historically been poor, though modern targeted therapies are improving the outlook significantly.
Let's briefly touch on hairy cell leukemia, HCL. It's a rare B-cell neoplasm with a very distinct look.
It is. HCL is highly associated with the BRAF V600E mutation. Morphologically, its name is perfectly descriptive. If you look at the images in figure 13.17, the cells have fine, hair-like cytoplasmic projections that are visible under phase contrast microscopy.
And clinically, it leads to cancytopenia and splenomegaly. But the diagnosis is often complicated by a bone marrow procedure that yields very little material.
Ah, yes, the dry tap phenomenon.
All right.
The HCL cells induce significant marrow fibrosis. The bone marrow gets replaced by fibrotic tissue, making aspiration nearly impossible. Fortunately, HCL is one of the most treatable leukemias, responding dramatically and with long-lasting effect to purine analogs.
We should also briefly mention multiple myeloma, the most famous of the plasma cell neoplasms.
Yes, myeloma is a clonal proliferation of plasma cells in the bone marrow that secretes a massive, measurable amount of monoclonal immunoglobulin. We call this the M protein.
And the classic clinical presentation is pretty destructive.
It is. It involves bone destruction seen as lytic lesions or punched-out holes on X-rays. This often leads to fractures, high serum calcium levels, hypercalcemia, and potential renal failure. The bone marrow aspirate reveals sheets of atypical plasma cells.
Okay, let's move into our next major section, Hodgkin lymphoma. This contrasts sharply with the non-Hodgkin lymphomas we just covered.
It's a completely different beast. Table 13.7 lays out the fundamental differences in how they behave.
What's the key behavioral distinction?
It's the spread pattern. HL typically starts at a single axial lymph node or chain-like in the neck or chest, and spreads predictably, contiguously, from one adjacent node to the next.
It's orderly.
It's very orderly. NHL is messy. It often involves multiple peripheral nodes, the Waldeyer ring, and frequently presents outside the lymphoid system, which we call extranodal.
But the true, absolute defining feature of Hodgkin lymphoma is the presence of the neoplastic giant cell, which often comprises less than 10% of the tumor mass itself.
That is the Reed-Sternberg cell, the RS cell. These cells are absolutely massive, and the bulk of the mass isn't the cancer cell. It's the non-neoplastic, recruited inflammatory cells. It's a cancer that is defined by its microenvironment.
Let's look at the microscopic description of these critical cells. Figure 13.24 shows them beautifully. What is the classic presentation? The one that gives it the memorable nickname.
The classic RS cell is large, often binucleated or multinucleated, and each nucleus contains a huge inclusion-like nucleolus surrounded by a clearing of cytoplasm.
And that gives it the characteristic owl's eye appearance.
The owl's eye, that's the one you never forget once you've seen it.
And the variants are crucial for subtyping the disease.
Yes. The lacunar variant, for example, is typically found in nodular sclerosis HL. Due to a fixation artifact, the RS cell shrinks away, leaving it sitting in an empty space, a lacunae.
And then there's the special variant found in nodular lymphocyte predominance HL.
Right, the LNH cell, or, more memorably, the popcorn cell. It features a polylobated, convoluted nucleus that looks, indeed, like a piece of popped corn.
It's truly amazing that a tumor cell that makes up such a small fraction of the mass drives the entire disease. What is the origin of the RS cell, and how does it so effectively manipulate its environment?
The RS cells are traced back to germinal center B cells that failed their maturation and apoptosis checkpoints. And central to their survival is the constant activation of the transcription factor NFPA.
And that gives them a perpetual pro-survival signal.
Exactly, but survival alone doesn't create a massive tumor mass.
Right, so what does?
The RS cells act as molecular manipulators. They pump out massive amounts of cytokines and chemokines. These signals recruit a powerful bystander immune response: T cells, eosinophils, plasma cells, macrophages.
So the tumor cell's calling in all these other cells.
It is. And this recruited inflammation provides the necessary survival signals and nutrition for the RS cells. It constitutes the bulk of the tumor mass, and it's responsible for the systemic symptoms like fever, night sweats, and weight loss. The famous B symptoms.
So the B symptoms are caused by the inflammatory response, not the tumor cells directly.
Precisely.
Let's talk subtypes. Nodular sclerosis, or NSHL, is the most common subtype, generally affecting young adults.
NSHL accounts for 60 to 70% of cases. Its morphology, shown in figure 13.25, is defined by broad, orderly bands of dense collagen or sclerosis that divide the lymph node into distinct nodules.
So it's an important visual identifier.
It is, and it features that lacunar RS variant we mentioned. The prognosis for NSHL, especially in early stages, is excellent.
The other classic subtype is mixed cellularity, or MCHL.
MCHL is common in older adults. It's often associated with EBV infection, and it contains the classic owl's eye RS cells within a more diffuse inflammatory background.
And then there is the black sheep of the family, nodular lymphocyte predominance HL, NLPHL.
NLPHL is an important outlier because it is immunologically distinct from the rest of classic HL.
How so?
Its neoplastic cells, the popcorn cells, express B-cell markers like CD20, whereas the classic RS cells in NSHL or MCHL are typically CD15 plus and CD30 plus, but have lost their B-cell markers.
So that difference in their fingerprint means it behaves differently.
It behaves and is treated slightly differently, yes.
The Ann Arbor classification is the standard for staging based on anatomical location relative to the diaphragm. But B symptoms, fever, night sweats, weight loss, are crucial prognostic indicators.
Staging is everything for HL treatment planning. Stage 1 is a single node region. Stage 2 involves multiple regions on the same side of the diaphragm. Crossing the diaphragm makes it stage 3.
And the presence of B symptoms bumps the stage up.
It indicates more aggressive disease, even if it's localized.
While HL is one of oncology's greatest success stories, cure rates around 90% for early-stage disease, the discussion always turns to the long-term cost of that cure, particularly for young survivors.
That's right. The combined chemo and radiotherapy regimens used decades ago, while curative, resulted in a significantly increased risk of secondary cancers, breast cancer, AML, and melanoma many years later.
Which has driven the modern approach to de-escalate treatment.
Exactly. The goal now is to minimize radiation exposure whenever possible.
And this brings us back to the microenvironment manipulation. We need to set the stage for our final thought, the role of immune checkpoint inhibitors in HL.
We noted that RS cells are molecular manipulators that recruit T cells. They also express high levels of PD-L1 and PD-L2.
The checkpoint proteins.
Right. These ligands bind to the PD-1 receptor on cytotoxic T cells, and that effectively puts the T cells to sleep. It causes T cell exhaustion. This immune suppressive mechanism is critical for the RS cell survival, and it is a key difference compared to many other lymphomas we discussed, like CLL or follicular lymphoma, where this PD-1, PD-L1 expression is typically less significant.
We will definitely come back to that, but first, we transition to myeloid neoplasms.
Okay.
These are cancers arising from the factory floor, the hematopoietic progenitor cells of the myeloid lineage.
Right. So granulocytes, monocytes, platelets, and red cells. This huge group is divided into 3 functional categories.
And those are?
Acute myeloid leukemia, or AML, myelodysplastic syndromes, or MDS, and myeloproliferative neoplasms, or MPN.
Give us the one-sentence summary of each.
Okay. AML is the acute crisis of the adult bone marrow. MDS is the functional failure of the marrow, and MPNs are the chronic overproduction disorders.
Perfect. Let's start with AML. It's defined by the accumulation of immature myeloid blasts, requiring a minimum of 20% blasts in the bone marrow.
And it's the most common acute leukemia in adults. Pathogenesis is often described by the 2-hit model.
The 2-hit model.
First, you get a mutation that interferes with normal myeloid differentiation. It blocks the cell from maturing past the blast stage. Second, you get a mutation that causes constitutive, non-stop activation of growth signal pathways, such as mutations in the FLT3 receptor tyrosine kinase.
So one hit stops it from growing up, the other hit tells it to divide forever.
That's the perfect combination for disaster, an accumulation of perpetually immature, rapidly dividing cells.
The modern WHO classification relies heavily on cytogenetics and genetic abnormalities because those define prognosis far better than pure morphology.
Absolutely. AML with translocations like T821 or inversion 16 generally implies a favorable prognosis because those blasts retain some degree of maturation potential. Conversely, AML associated with prior therapy or prior MDS carries poor cytogenetics and a dismal outlook.
Let's focus on the morphology, the definitive identifiers for AML, particularly the feature pathologists live by.
In the bone marrow aspirate, like in figure 13.31, you see large myeloblasts. But the pathognomonic finding, the smoking gun, is the presence of Auer rods.
Auer rods.
These are azurophilic granules that have crystallized into red rod shapes within the cytoplasm. Finding just one Auer rod is definitive proof of AML, and it excludes all.
And AML has a particularly dangerous subtype associated with a severe bleeding risk.
That's acute promyelocytic leukemia, or APL. It's driven by the T1517 translocation, which creates the PML-RRA fusion gene.
What do the cells look like?
The promyelocytes are often loaded with granules that obscure the nucleus, and APL is specifically associated with severe disseminated intravascular coagulation, or DIC, because those granules release procoagulant factors that trigger widespread, catastrophic clotting and bleeding.
It sounds like a true medical emergency.
It is. However, APL is one of the greatest success stories in targeted therapy.
How so?
The source highlights the revolution caused by all-trans-retinoic acid, or HRA. HRA binds to the mutant RRA protein and forces the immature promyelocytes to differentiate.
So it makes them grow up and die.
It drives the blocked cells to mature and die naturally, inducing remission without the toxicity of traditional chemotherapy alone. It's a beautiful example of targeted therapy.
Okay, next up, myelodysplastic syndromes, or MDS.
Myelodysplastic syndromes are related chronic disorders. The bone marrow is often highly cellular. It's trying desperately to make cells, but the process is dysplastic.
Meaning disorganized and abnormal.
Disorganized, abnormal, and fundamentally ineffective. The result is peripheral cytopenias, low counts in the blood, and a high risk of transforming into aggressive AML.
So the cells are being made, but they are defective, like parts coming off a miscalibrated assembly line. What are the key morphological signs of this dysplasia?
We look for specific morphological errors across the lineages. In red cell precursors, we see ring sideroblasts, which is iron accumulating pathologically around the nucleus.
What about the other cell lines?
In the granulocyte line, we see nuclear abnormalities like hypersegmented or abnormally small nuclei. In megakaryocytes, the platelet precursors, we see the classic pawn ball megakaryocytes, shown in figure 13.32. They have these single, multilobulated, or wildly separated nuclei instead of the normal, single, densely lobed structure.
Prognosis here is dictated primarily by how many of those defective cells are already full-blown blasts.
That's the key. Survival ranges significantly, but the higher the percentage of blasts, even if it's below the 20% AML cutoff, the higher the risk of progression and the worse the prognosis.
Okay, the final major category, myeloproliferative neoplasms, or MPNs.
The MPNs. These are characterized by a common pathogenic feature, the presence of mutated, constitutively activated tyrosine kinases, leading to an excessive production of mature blood cell lines.
So the factory is in overdrive, but it's making finished products. Let's start with chronic myeloid leukemia, or CML.
CML is the MPN definition. It is defined by the BCR-ABL fusion gene on the Philadelphia chromosome, resulting from the T922 translocation. This creates a perpetually active BCR-ABL tyrosine kinase.
That constant signaling must drive massive, uncontrolled production.
It does. Microscopically, the peripheral smear shows massive leukocytosis often counts over 100,000 cells per microliter.
A huge number.
A huge number. But crucially, unlike AML, the circulation contains a full spectrum of maturing cells. Mature neutrophils, metamyelocytes, myelocytes. It reflects an orderly but massive overgrowth of the factory. The spleen, as you can see in the gross photo, is often hugely enlarged.
CML is famous for its regression through 3 distinct phases.
It is. It starts in the chronic phase with an insidious onset and mild symptoms. It then enters an accelerated phase with more blasts and rising counts and, inevitably, a blast crisis.
Which is basically a transformation to acute leukemia.
Transformation to acute leukemia, which can be AML or, surprisingly, sometimes ALO. Like APL, CML treatment was revolutionized by targeted therapy. BCR-ABL inhibitors, like imatinib,
which specifically block that mutant kinase.
They block it cold. They return the factory to normal output and have transformed CML from a fatal disease into a manageable chronic condition for most patients.
Next, MPN. Polycythemia vera, or PCV. This involves the increased production of red cells, though granulocytes and platelets are often increased too.
PCV is driven, in over 90% of cases, by the JAK2V617F mutation.
What does that do?
This mutation constitutively activates the JAK-STAT signaling pathway, making progenitor cells hyper-responsive to all growth signals.
And there's an important diagnostic giveaway in the lab work.
There is. Despite the high red cell count circulating erythropoietin, or EPO, levels are characteristically low. The body recognizes it has too many red cells and turns off the signal, but the progenitors are ignoring the control signal because of the mutation.
The clinical danger is rooted in the increased blood viscosity.
Exactly. The symptoms, headaches, dizziness, a ruddy complexion are uncomfortable, but the true danger is the significantly elevated risk of thrombosis or clots in both arteries and veins.
And what's its long-term course?
PCV can eventually transform into myelofibrosis or AML.
Okay, briefly on the last two. Essential thrombocythemia, ET, and primary myelofibrosis, PMF.
Essential thrombocythemia, or ET, is the MPN defined by an unexplained high platelet count. It's typically associated with JAK2, CALR, or MPL mutations. The peripheral smear in figure 13.37 just shows extremely numerous, often large platelets. The risk is paradoxical. Patients can have both clotting and paradoxical bleeding.
And primary myelofibrosis, PMF. The name tells us it involves marrow fibrosis, which sounds like total factory shutdown.
It is. PMF involves the obliterative replacement of the bone marrow by dense fibrosis. This forces the body to produce blood elsewhere, a process called extramedullary hematopoiesis.
And that happens where?
Primarily in the massively enlarged spleen and liver.
And the peripheral blood smear gives us a unique, highly characteristic shape of red cell, confirming the destructive forces in the marrow.
Yes. The marrow is so scarred and stiff that red cells are literally squeezed out. This results in the classic finding of teardrop red cells, or dagrocytes, as seen in figure 13.38. This morphology, combined with massive splenomegaly and immature cells spilling into the circulation, is highly suggestive of PMF.
We spent the bulk of our time on the production and surveillance systems. Let's finish by looking at 2 critical organs that govern these processes: the spleen and the thymus.
The supporting cast.
The supporting cast. Let's start with the spleen.
The spleen is fundamentally divided into the white pulp, which is the organized lymphoid tissue hosting T cells and B cells, and the red pulp, the vascular tissue that acts as the blood filter.
What are the spleen's primary non-negotiable jobs?
Its main functions are blood filtration, removing old or damaged red cells, its pitting function, and initiating immune responses, particularly crucial against encapsulated bacteria.
Which is why if you lose your spleen, you are vulnerable to these specific types of infections. Now, Enlargement of the spleen, or splenomegaly, is the most common clinical manifestation of splenic disorders.
It is. And splenomegaly, which is a spleen over 350 grams, has a major consequence called hypersplenism.
What's that?
The hyperactive enlarged spleen acts like an overzealous bouncer. It sequesters and destroys normal blood cells, leading to pancytopenia low counts of red cells, white cells, and platelets.
The causes are vast, but they tend to fall into categories.
The four major categories are infections like mononucleosis or malaria, lymphohematogenous disorders like CML or CLL, which often cause massive splenomegaly, immunologic disorders like SLE, and congestive states like portal hypertension secondary to cirrhosis.
Okay, briefly on the thymus. The essential training ground for T cells, which we know is most active in childhood, and then involutes after puberty.
The thymus is responsible for T cell maturation, ensuring T cells are functional but also self-tolerant. They learn not to attack the body's own tissues.
And developmental disorders are a big problem.
A huge problem. Thymic hypoplasia, or aplasia, is famously seen in DiGeorge syndrome, where patients have severe T-cell immunodeficiency because they lack the training ground.
And finally, thymomas. These are neoplasms of the thymic epithelial cells.
Right. They occur in the interior superior mediastinum. They are classified based on cytology of the epithelial cells, ranging from benign to invasive or malignant. Microscopically, we see a mixture of these epithelial cells interspersed with a large number of immature T lymphocytes.
But the tumor itself is defined by the epithelial cells.
Correct.
The clinical relevance of the thymoma is overwhelmingly tied to a specific paraneoplastic syndrome.
It is. The most common paraneoplastic syndrome occurring in up to 40% of thymoma patients is myasthenia gravis, an autoimmune neuromuscular disease.
And that connection underscores the thymus's fundamental role in regulating immune self-tolerance.
Exactly. When it goes wrong, the consequences can be systemic.
Okay. We have completed an exhaustive review of this material.
We have. We've moved systematically from the delicate, factor-regulated balance of hematopoiesis through the highly characteristic morphology of reactive states, and finally into the organized classification of hematologic malignancies.
So for you, the learner, the key takeaways are twofold. First, the predictive power of cytogenetics is your ultimate cheat sheet.
Absolutely.
Knowing that BCR-ABL means CML, T1418 means follicular lymphoma, and the MYC translocation means Burkitt provides the instant diagnostic and prognostic foundation.
And second, master the crucial microscopic identifiers. The aha moments we highlighted on the H&E slides, the Reed-Sternberg cells, the owl's eyes defining Hodgkin lymphoma, the hour rods, the pathognomonic crystals for AML, the story sky pattern, which must be interpreted carefully to differentiate healthy cleanup from aggressive Burkitt proliferation, and the teardrop cells signaling myelofibrosis.
Understanding the interplay between the genetic drivers and the resulting cellular morphology is truly appreciating pathology in depth.
It is.
So what does this all mean for the future of treatment? We highlighted that classic Hodgkin lymphoma is highly responsive to immune checkpoint inhibitors.
We did.
And that's because the Reed-Sternberg cells are incredibly reliant on manipulating that non-neoplastic bystander inflammation by expressing PD-L1.
Right.
This mechanism is often less critical or completely absent in other common lymphomas we discussed, like CLL or follicular lymphoma.
And that raises a really important question. Since so many aggressive cancers, not just HL, rely on manipulating a non-neoplastic tumor microenvironment, whether that's immune cells, blood vessels, or fibroblasts for survival and evasion, how might this targeted approach, exploiting the immune microenvironment rather than just trying to kill the tumor cell itself, revolutionize the treatment of other aggressive cancers that are currently resistant to traditional chemotherapy?
Because you're saying we should stop just targeting the cancer cell.
And start targeting the support structure it has built for itself. It asks us to look beyond the malignant cell and target the entire ecosystem it creates.
The fascinating paradigm shift to leave you with. Thank you for joining us on this deep dive into hematopathology.